Hello and welcome to the Clinical Update podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Rhiannon, Deputy Editor at MIMS Learning, and it's New Year's Eve. So in the spirit of reflection, I'm looking back at some of our highlights from 2025. We've had so many fantastic guests over the past 12 months who've brought interesting insights and learning tips. And in this episode, we're going to revisit interviews on cancer diagnosis. We'll hear some advice on weight loss injections, get some tips on managing chronic kidney disease, and gain some practical tools that you can use to spot people who may need help to address their alcohol use. Then finally, I'll leave you with a little something to bolster you as we head into 2026. So let's get started. This year, the MIMS Learning editors have focused our efforts on producing education to support you to spot cancer earlier and make best use of referral pathways to optimise diagnosis. There's an absolute trove of learning material on this available on the campaigns tab on our website, mimslearning.co.uk, which I'd really encourage you to take a look at. Now, it's often noted that the UK lags behind other European countries in terms of early cancer diagnosis, and there's no doubt that this topic can be anxiety-inducing for patients and clinicians alike. But looking back on this year, I wanted to draw out some moments that have left me feeling hopeful. Back in January, I spoke to Professor Peter Johnson, National Clinical Director for Cancer at NHS England, and we talked a bit about how the goal set out in the 2019 NHS long-term plan was going. Now, as a reminder, that goal was to diagnose 75% of cancers at an early stage by 2028. And one recent development we covered was the rollout of the lung cancer screening programme. Here's what he had to say.
Historically, the likelihood of being diagnosed with early stage lung cancer is about 25 or 30% if we wait for people to present with symptoms. In the screening programme, we've now diagnosed more than 5,000 people with lung cancer since we've started rolling it out in the last few years. And 3/4 of those have been picked up at stage 1 or 2, so a huge shift in the stage at diagnosis. We've been rolling the programme out progressively across the country, and because we've been concentrating in those areas of greatest deprivation, what we've seen is that the usual difference between the likelihood of being diagnosed with early stage lung cancer between the best off and the worst off, which used to be that better off people were more likely to be diagnosed with early stage cancer by about 8 percentage points. That has inverted now, and actually it's people who are in the most deprived areas who are most likely to be diagnosed with early stage lung cancer, because we've been using this screening program specifically to target those populations.
I was really encouraged by what Professor Johnson said there, especially the news that health inequalities around diagnosis in these specific cases have really effectively been addressed. And I felt that was really encouraging in a cancer that's notoriously difficult to spot early. Now, another cancer for which this challenge holds true is pancreatic cancer. And among the learning materials I mentioned, you'll find a module by Dr Pipin Singh outlining the red flags to look out for. It's available as an audio version too, if that's what you prefer. But of course, symptoms are often non-specific, and a shocking 80% of people are diagnosed at a late stage with pancreatic cancer, with more than half dying within 3 months of a diagnosis. It's been 5 years now since my own dad died of pancreatic cancer just 4 weeks after being diagnosed. But there is hope that in the near future, the landscape of early pancreatic cancer detection might look much more favourable. Let's hear a clip now from when I spoke to pancreatic cancer specialist nurse Rachel Richardson last month.
So Pancreatic Cancer UK are funding the development of the world's first breath test that can be used in the GP surgery to improve the early detection of pancreatic cancer. And this work is being led by Professor George Hanna at Imperial College in London, with the research team there carrying out a study in over 700 people, both with and without pancreatic cancer, to find out how effective the test is in detecting pancreatic cancer. Results are looking promising, and we should be able to share more about that soon. All being well, we're hoping to move to a larger clinical trial by the end of the year. So I totally agree that the challenge of vague, non-specific symptoms and late presentation is huge. But having a test that is readily available in primary care that allows health professionals to identify patients that require further investigation would be such a step forward in ensuring that people are diagnosed at an earlier stage.
So we heard there from Rachel Richardson about one potential primary care test for pancreatic cancer. And the CEO of the Pancreatic Cancer UK charity, Diana Jupp, actually wrote on their website that the test has the potential to revolutionise the early detection of pancreatic cancer, and that it's the most significant step toward a life-saving breakthrough in 50 years. So I'm feeling really hopeful for the future. But returning now to the present, one topic that has been making the headlines this year is weight loss injections. Speaking to MIMS Learning editor Pat in the summer, Dr Toni Hazell, a GP and board member at the Primary Care Women's Health Society, said that newer weight loss medications are a game changer for many people.
We know that about a quarter of adults are living with obesity, about 2/3 with overweight or obesity, probably about 1 in 8 children under 10. And we all know about the health consequences of this in terms of diabetes, cardiovascular disease, but also cancers, which I think people don't maybe think of so much, particularly from a woman's health perspective, endometrial and breast cancer. And I think there is a really clear need to see this as the medical problem that it is, rather than perpetuating this stigma that people are just lazy and greedy and they don't understand. And if they did understand, then they'd behave better, because that's obviously not true.
So you heard Dr Hazell there emphasising the impact of obesity on women's health particularly. And she went on in this interview to say that the cohort using GLP-1s for obesity may be more likely to be women of reproductive age than the cohort using them for diabetes, who possibly on average will be a bit older, which means that there will be some specific considerations for anyone prescribing these weight loss medications. Firstly, evidence for their use during pregnancy is obviously lacking at the moment, which means that women taking GLP-1s may require contraception. What's more, Dr Hazell reminds us that weight loss can improve fertility, making effective contraception even more important. Here's Dr Hazell talking about the College of Sexual and Reproductive Health guidance on oral contraception.
So there's some concerns that there is a clinically significant effect on the bioavailability of oral contraception for tirzepatide only, and therefore women should use a non-oral method for 4 weeks after they start the drug and 4 weeks after every dose increase, or they should add a barrier method such as a condom. Now, women taking tirzepatide for obesity, unless they're limited by side effects, they might well increase the dose every 4 weeks. That's quite standard. Not all people taking it do, but some do. And therefore, you've got quite a prolonged period of time when an oral contraceptive isn't necessarily going to be effective, and people might not like to use condoms, and condoms have a high failure rate. So it's certainly worth discussing changing to a non-oral method like the patch if there's no contraindications to estrogen, or the depot injection, or the implant, or the intrauterine device, or coil as patients continue to call it. It's not officially called a coil, but I don't think patients will ever stop calling it a coil. And the other issue with contraception, obviously, is that sometimes these medications can cause diarrhea and vomiting as a side effect. And then those women who are taking oral contraception would need to follow the normal rules about diarrhea and vomiting, although hopefully they're not relying on their oral contraception. They've got either a barrier method or they've switched.
So as we all know, obesity is a complex condition governed by an interplay of myriad physiological and societal factors. And CVRM disease, of which obesity is a feature, has been another key topic of discussion in recent years. Back in September, I spoke to consultant physician and nephrologist Dr Andrew Frankel about a typical, albeit hypothetical case of a 66-year-old man of South Asian heritage who has type 2 diabetes, hypertension, ischemic heart disease, and who now appears to be developing kidney disease. Dr Frankel and I spoke about lifestyle interventions, which Dr Frankel said are the foundation of improving outcomes for people with or with developing CKD. And we then went on to talk about pharmacological treatment, which he said remains central to the modern management of individuals with cardiorenal disease. So in this clip that I want to share with you, Dr Frankel's just highlighted an initiative launched by the London Kidney Network called 3 Actions in 3 Months to Save Lives.
This encourages medicine's optimization early and effectively in people with kidney disease. The recommendation is that where you identify someone with chronic kidney disease, that you maximize the inhibition of renin-angiotensin system inhibitors, such as the ACE inhibitors or angiotensin II blockers, to their maximal tolerated doses within a month rather than what we tend to do currently, which is do this over a period of years. You then add in the SGLT2 inhibitor in the second month, and then in the third month, you adjust the blood pressure medications, the additional blood pressure medications, to target the blood pressure, because the SGLT2 inhibitors and the renin-angiotensin system inhibitors will both lower blood pressure. I would highlight that there are now additional treatments for people with diabetic kidney disease. This includes non-steroidal mineralocorticoid receptor antagonists, such as finerenone, which should be considered to be added onto this regime. The rollout of this drug is variable across the country. We also know that the GLP-1 receptor agonists have a powerful kidney and cardiac preventative effect in addition to their diabetes and weight-reducing properties.
The clip you just heard there was part of a 3-part podcast series, a unique new learning approach that we launched this year, a collection of podcasts and other learning material including reflective prompts, key learning points and multiple choice quizzes. And as a little festive gift for our learners, we've recently made this series free for a limited time. So if you'd like to hear more of this case-based learning, which you can listen to on the go, then do go to our website mimslearning.co.uk and search podcourse. Now, at this time of year, you may encounter people who are concerned about their or someone else's drinking. So I want to revisit now a conversation that my colleague Dawn had with Dr. Steve Brinksman back in October. Dr. Brinksman's a GP in Birmingham and medical director for Cranstoun, a charity providing substance misuse services. And he reminded us that alcohol use disorder is very, very prevalent and that the harm occurs long before people have physical dependence. Here he is giving some tips on how to effectively assess someone's alcohol consumption and also explaining why there is reason to be optimistic about treatment for alcohol use disorder.
I think the trouble with saying to people, how many units do you drink, is everybody's immediately on the back foot and playing a defensive shot, and they're sort of thinking, what do I say that seems reasonable? It's not a very accurate way of assessing people's alcohol consumption. So that's why we would always recommend using one of the validated screening tools. The one that I use the most is called AUDIT, the Alcohol Use Disorders Identification Test. It was developed by the World Health Organization and it was tested in many, many countries. And it's 10 questions that ask people about how often they consume alcohol and when and what their effects of that might be. And it can actually be administered by the clinician, but it can also be given out to patients to fill in themselves. It's got a very high sensitivity and specificity, both well over 90%. So it's very good at spotting people who do have a problem with their alcohol use. Clinicians actually quite good at spotting people. If a clinician thinks you've got alcohol problems, they're normally right, but there's an awful lot of people who've got alcohol problems that the clinician doesn't suspect, which is why the audit is better. A lot of people feel that alcohol dependence is refractory to treatment, that there's nothing you can really do. I hear people saying, well, until you hit rock bottom, you won't get any better. And that's actually not true at all. There was a large trial done many, many years in the UK alcohol treatment trial that showed that actually about 40% of people who were dependent stopped drinking following treatment, and of the other 60%, over half of those significantly reduced their drinking. We're in the harm reduction business. Anything we can do to stop people developing diseases, to stop people having to go to hospital, that's worthwhile. If you've got treatment that improves 60 to 70% of people, then that's a very significant number.
So that positive outlook from Dr. Brinksman leads me to our final segment for today. Here at MIMS Learning, we're always inspired by the hard work and dedication shown by you, our learners, professionals on the front line of healthcare. So I hope that this next clip from a conversation between Pat and Dr. Farnaz Sharif, GP and resilience trainer, will help you to start off 2026 on a good footing, ready to take on the challenges and enjoy the successes of the year ahead.
What practical steps can people take to protect their own balance while supporting others?
I think the most important step is to be aware of how you're feeling and to act in accordance with that. If we are aware of the fact that our tank or our energy levels are a little bit low and we slow our pace down, we're able to manage that a lot better. Whereas if you notice that your tank or your energy levels are low, but you carry on plowing ahead, at 100 miles per hour, then you're more likely to hit burnout faster. So I think awareness of where you are in terms of your energy levels is really, really important. And once you know where you are, creating those very small but consistent, I think consistency is key here, consistent moments of recharge. In clinic, for example, I've had a really busy morning surgery today, and often it is, we spend 10 minutes with patients and it's one after the other. So if I do have a sort of challenging consultation, or if there is something that perhaps stresses me out a bit, I will take a few minutes to recharge before I call my next patient in. Because, what happens in that consultation is my responsibility, and I don't want to enter a consultation feeling depleted in terms of energy. So awareness of the fact, how are you feeling? And then taking a few minutes to recharge in between challenging situations is really important. And recharging can be something as simple as, making sure you're sitting upright so your energy flows upwards, resetting your breathing, perhaps refocusing your thoughts, or even getting up and grabbing a cup of coffee from the reception desk. Do something to change your physical state so that, the blood's flowing differently in your system, even if it's for 2 minutes, and allowing your energy to sort of move in an upward direction. And these are the kinds of frameworks. These are just a few examples I've given you, but we have a lot of frameworks that we can use to help people pause, reflect, and deal with their challenges perhaps with a bit more clarity rather than reacting to them if they're feeling very, very tired. And what's nice about these frameworks is that when people use them and they use them again and again and they find that it works, then it can really transform the way in which they function when they're dealing with stressful situations.
So that's it for today. You've been listening to the MIMS Learning Clinical Update podcast produced by Jude Owen. I've enjoyed this trip back down memory lane. We've had over 22,000 downloads of this podcast this year, so I'd like to thank all of you who've listened in 2025. And if you've enjoyed these episodes, please do recommend us to a friend or a colleague and leave us some feedback on the podcast players. We hope you'll join us again in 2026. Bye for now.